It's been quite a journey to watch the Deming Cup grow over the last decade, and a true pleasure to have been able to witness it from its inception and from sort of a front row seat. This year, of course, is like no others, as we have heard. We have experienced an unprecedented crisis that has brought really to the fore incredible leadership that we recognize this evening. This year, we're proud to honor leaders in healthcare who have shepherded us through such uncertainty, and I join all of you in saluting the vast accomplishments of our three winners. And while we celebrate Michael, Kevin, and Craig tonight, we also salute the thousands of colleagues who have joined them on the front lines. The Deming Cup, as we heard earlier on, recognizes operational excellence. And it is important to recognize that apart from your incredible, I would say relentless, constant, unwavering leadership over this past year, the operational resourcefulness and ability to execute with quality, at scale, and under duress was and continues to be simply remarkable. And this we recognize again today. And while your leadership has been tested in 2020, it is important to also recognize the leadership that emerged in all of our environments and communities, from our frontline workers to our community volunteers and leaders. I would say one person at a time. I'm sure we're all looking forward to unwinding this crisis next year and a calmer and less exciting 2021. At Columbia Business School, our primary role is preparing and shaping future business leaders. An occasion like this bring us face to face with exemplary leadership, and it's really our pleasure to share this experience as a community. Now, my role ends with the distinct pleasure of welcoming my colleague, Dr. Vafa El-Sadr, who has been really at the forefront of leading through this crisis in public health now and in over the past decades. Vafa is an amazing scholar and an impactful leader and a good friend. She's recognized by Columbia's highest academic honor of being one of only 17 university professors. These are professors that serve across disciplines and across all schools for the institution. And to just recognize the importance, this is a distinction that only 17 individuals have out of 4,370 faculty members that we have at the university. Vafa's recognitions are too many to list, but I'll give you a little factoid that over the span of 1 year, she was recognized as a MacArthur Fellow, also called the Genius Grant, and by the Rolling Stone magazine as one of the most influential people of our country. A true rock star, I would say. So closer to home, she has been reassuring. It has been reassuring for all of us that she has been guiding our own public health task force at Columbia, and has been a truly great friend and ally of our school in our reopening over the last 2-3 months. We are grateful to her for everything that she's doing and for carving out some time to be with us tonight. So Vafa, the floor is yours. Thank you for being with us.
And thank you very much, and good evening, everyone. And thank you, Costis. It's a great pleasure to be here with you tonight and to moderate a conversation with the 3 awardees of the Deming Cup for this year, for 2020, Kevin, Craig, and Michael. To start the conversation, before we start looking at the now and the future, I wanted you to think back and maybe think back to the one thing in your training or your personal or your professional experience that you feel really enabled you to deal with the COVID-19 crisis. What is the one thing that kind of created you and made you the leader that was able to stand firm and tackle this crisis? And I guess I see Craig first. So Craig, why don't you start?
Well, Vafa, thank you for letting me at least address that. I would say it was actually remembering why I went into medicine in the first place, why I became a doctor, which was to help other people. And in the end, with all the other things stripped aside, healthcare is about delivery by people for other people. And that mission has seen me through other crises, one you know well. I was a house officer in my medical training as a doctor when the HIV epidemic hit, and understood that made many of us question the risks we were taking and the patients for this unknown disease. And this was a preparation of going through that during my training to understand why we went to healthcare, to provide the communication that was necessary to remind all of the staff, all 20,000 at all levels of the institution who came to work, that this is why we had a mission. And it was to see these cancer patients through to the other side of their cancer treatment while being exposed, as the whole population was, to cancer. And so it really reinforced that mission and what our past experiences are critical, and our communication skills that we learn as physicians, as nurses, and as healthcare leaders, in the case of Michael and Kevin and myself, really provided us the background to be part of the healthcare force, which came together as a team to take care, as was said throughout the award ceremony.
Thank you, Craig. And maybe I'll move on to Michael. When you think back, what comes to mind?
Well, I think, healthcare has always been the area that I've wanted to be in. But to your direct answer to your question is, I think, I left home when I was very young. And so risk-taking and dealing with difficult circumstances has been something I'm very used to. I've been by myself. I left home when I was 16. And, I went to England first, then came to the US. So when you go through those kinds of circumstances, difficult situations, you put everything that's difficult in perspective. Because whenever we think we are in a difficult circumstance, you can always think of 1,000 other individuals or other groups of people around the world that are in situations so much more dire than the situation you're in. So it makes the situation you're in comparison, relatively mild. And I think it's important to keep that perspective. Even in the height of the COVID crisis, I kept telling people, just think of the people who are now living in Afghanistan, in Iraq, or in other parts of the world who are in dire circumstance with very little possibility for a substantial future. So when you look at it in that context, it changes the way you look at things. And so and the other thing for me was I spent a lot of time in government, and I was one of the leaders in the state government for a long time. So I dealt with the crack epidemic, I dealt with the AIDS crisis, I dealt with the homeless crisis, I dealt with the unbelievable tragedy of child abuse. So all of those travails and travels, in many ways, I suppose it toughens you up, but it gives you perspective. And I always tell people, no matter how bad you think you're having it, look around. You're very fortunate.
Thank you. And what about for you, Kevin?
Yeah, well, thank you for the question. Thank you for moderating tonight. I would say something similar, but a little different. When I began as a bedside nurse, when I became a nurse, it was not common for men to be in nursing. So I went into nursing as an oncology nurse because I wanted to make a difference in people's lives. And I learned the value and the importance of believing. And what I mean by that, I strongly believe that to be a senior leader, you have to understand your value system and how it aligns with the organizational values. And for me, believing brings to the front of the line faith and also the opportunity to advance the purpose of the organization. And so recognizing what we went through as a team and the multiple discussions and multiple opinions, and I would echo what my colleagues said about being on the front lines of HIV. As a bedside nurse, I knew the policies were going to change every day, but what I had to remind myself was there's a whole part of our workforce that never lived that didn't realize that that was normal. And so making sure that people they were not only being communicated with, but also understanding why it's changing so rapidly, because we were understanding. And in closing, I would say the following. While I'm honored and privileged to be the president of Johns Hopkins Medicine and Johns Hopkins Health System, I would say the following to you. At the end of the day, the most important role are the people on the front line. And you have to, as a senior leader, believe in them and be present so that they can deliver on the promise by being present and supporting them. So those were some lessons that I learned many years ago that's been reinforced through going through this experience.
Thank you. So I hear from you the importance of the belief and the mission and the values, and as a driving force that has guided you all along and was able to sustain you during this very difficult time. I'm wondering, though, I'm going to move to the crisis itself, the COVID-19 crisis, and I know that healthcare systems overall are very much committed to having amongst the health workforce a well-trained and skilled workforce. But I think there's an aspect, a third aspect, which we call a resilient workforce. And by that I mean, as you well know, resiliency is sort of the ability to respond to crises and effectively respond to the crises, as well as to learn from the crisis. And what do you think about how this experience will shape the way you will think of your workforce in the future, of this aspect of resilience, in addition to the traditional training and skills building that we all do in the healthcare system? Maybe I'll go now to Michael.
Well, I think that healthcare workers on a regular basis that display extraordinary resilience and adaptability, and they deal with the unknowns all the time. When you come in as a nurse or a doc into the facilities each and every day, you never exactly know what you're going to deal with. It changes. You may think you're doing one thing, and all of a sudden the next couple of minutes you're doing something different. And during COVID, of course, this was the big unknown. You came in one day and you were dealing with a virus that you didn't have an awful lot of experience with. So I think in the very nature, the people who go into healthcare have this adaptability and this resilience and this core character that is strong, especially nurses and physicians and respiratory therapists and others. And so I think that going forward, what I like to do is make sure that when we bring people into the organization, when we recruit, that we're looking for people with certain kinds of characteristics, people who are really committed and passionate about what it is they do, who really care about what it is they do, who are interested in making sure that it's not about them, it's about the patient and the customer, and it's not about what they think, it's about what the customer wants. And we spend, in my organization, we spend a lot of time with new employees. So I, for example, meet every single new employee that enters the organization, and we hire about 150 to 100 a week. And so I'm always searching for the people with those kind of certain characteristics. And I think that that will be continuing to be a major ingredient going forward. Because otherwise, COVID demonstrated that it's the people on the front line, as Kevin just said, and it's also the leadership on the front line that makes the difference. So one of the other things is making sure that the frontline leader is one of the more important people that you have in your organization. People don't leave a business, they leave their first line supervisor. And also people want to belong to a cause. And healthcare is one of the greatest causes you can belong to. So I think that I think it's innate in most healthcare people, but I think that we have to continue to emphasize that as we recruit and onboard at the very front. And it's everybody. This is just not doctors and nurses. This is security guards, environmental workers, people in the laundry, the people in the kitchen, etc. It's the whole constellation of people that matters, working as a team.
Great. And Craig, what about from your perspective? How do you create this sense of the resilience in your system and in your employees?
I think it's a great question. We've been blessed always at Memorial Sloan Kettering with having extraordinary resilient staff at every level of the organization, throughout the organization, from our frontline doctors and nurses to the facilities workers and everybody else. Everyone believes in our mission, and believes in helping patients at a time of trouble, because every one of our patients is coming to us because they have a diagnosis of cancer. But what I have learned from this crisis with COVID is one addition beyond that. We cannot take it for granted. We cannot take it for granted, that resilience. We have to, as organizations, step up and provide the support the staff needs to recover. This has been, as it's gone on for 6 months now, an incredibly trying time for all of our staff. And so putting in the psychological support, putting out times for them to have timeouts, to refresh themselves is critically important. And so I absolutely agree with Michael that you have to pick a staff from the beginning of your first encounter with them that has the trait of resilience, but you cannot take that resilience for granted. And COVID has taught that to all of us that work in frontline organizations, particularly healthcare.
Kevin, what about your perspective? And you're muted, Kevin. Yeah.
I'd like to take a little bit of a different direction. I'm glad Craig is a foodie and likes to cook, but I look at this as a layered cake. And COVID is only one part of the crisis that we've had to respond to in the midst of this pandemic. And, you know, when I round on our COVID units, I hear the staff being afraid of getting it themselves. I hear the fact that they go home and take their scrubs off before they enter the house and put it in the washing machine and go upstairs and shower before they touch their loved ones or their elderly parents that might be living with them. Then on top of that, we actually started to see with our underrepresented minority groups who had COVID, a higher death rate in African Americans. So if we think about our colleagues and our friends that were impacted by that, you start to raise the issue of health equity. And then secondly, I would say in the midst of that, we also saw the Latinx population actually see a higher positivity rate. In one of our zip codes in the city of Baltimore, we saw a 30% positivity rate. Through our interventions, we've now brought it down to 20. We have a lot more work to do culturally in that community. But it reminds me of the importance of leaders in healthcare in the future having empathy, passion, and the ability to talk about cultural competence, which leads me to another layer of the cake. You know, all of us on this call have witnessed many examples of social injustice. And when I look at that, I really think about how the virus has been politicized. And to our Asian colleagues and friends, I've heard stories of xenophobia and how they've been treated, which is just not acceptable. But I would also say that as I look at this, the other aspect of this is with the social injustice and the issues of structural racism and systemic racism, I'm finding that our leaders in our workforce are not prepared to have those difficult conversations in a meaningful way where they can understand what it looks like and help change the organization. And I've reached out to my peers and I'm finding that that is not unique to Johns Hopkins, that everyone is struggling with that. So I believe that's another core competency that leaders will need to have is how do you deal with racism in your workplace or structural and systemic? How do you evaluate it, assess it, and then how do you respond to it? And so those are, while I appreciate the resilience of our workforce, those are the layers of the cake that I've heard about as I've rounded.
Mm-hmm. Thank you. And maybe my final question is you are, unfortunately we're running out of time, but you know, we always, or I always think of the health system as, you know, a coin with two sides. There's the healthcare system, and you are three amazing leaders of major, massive healthcare systems. And there's the other side of the coin is the public health system. And Kevin, you mentioned the community and what's happening in the community and the public health response itself and how it links or doesn't link with the healthcare system. And I'm wondering if you can reflect on, you know, what worked, what didn't work. How did you overcome this divide that often exists to bridge that divide between the healthcare system and the public health system that's working within the community itself? And maybe I'll start with, I'll go back to Craig.
Well, I think that what you brought out is something very important in America. Over the last couple of decades, actually, we've underinvested in public health. We've taken for granted that everybody has a roof over their head and has food, and have not paid attention to the quality of healthcare screening, of the resources. And so there are discrepancies, as Kevin just talked about. The socioeconomic implications for health have been understood. We have not empowered the various organizations that we've seen on a national level that made America a real world leader in epidemiology and providing quality public health, a standard of care over the last century, has been eroded as we started to take it for granted. And we have got to reinvest in a healthy workforce, in preventing and maintaining wellness, not just in caring for illness. I am proud of how the healthcare community responded to COVID and dealing with the illness that was felt and the onslaught of people that were had overwhelming illness from their pneumonias from COVID and other complications that we've heard about. But I would really wished we had a greater attention to how we could have prevented it from the spread that we experienced that in New York overwhelmed us before we even knew it was in our community.
Thank you, Craig. And what about Michael? What's your perspective on this?
I would agree. I would agree with Craig. There needs to be a dramatic investment in public health. I mean, we nationally and regionally, we have neglected this over the years. And that is obviously something I think everybody would agree with. But I do think that we who run large organizations have to look at what we do a little differently. When we call ourselves health systems, but I'm not sure we are. We focus primarily on medical care, and medical care is a component of health. Mm-hmm. It is not the same as health. So the whole area of social determinants of health, lifestyle, behavior, social circumstance, prevention, wellness, is one of the things that I, at least in my organization, when people ask me what my vision would be over the next decade, would be to be able to convert ourselves to be able to be as good at the front side and the social determinant side and being a catalyst in that area. We can't do it all ourselves, but to be as good there and as focused there as we are on the illness treatment side. I think then I can say that we can stand up and say we're a great health system. Mm-hmm. And that is, I think, the guide for us as we go forward. And COVID, we've known this for a long time, but COVID, and Kevin mentioned this, COVID demonstrated the disproportionate effect that it had on certain minority populations and poverty populations. And we are working with many of those communities right now, as we were in the past, but we're intensifying our effort. But it shouldn't have taken a COVID crisis to make it so obvious that we did do an awful lot more. And you asked before about public and private. This is a private responsibility in part, but it is a huge public responsibility. And this is where you need that collaboration between private and public to get us to the point where we can say, with honesty, with sincerity, that we are actually a true health system. Until we do that, I think we're only dealing with one side of the equation.
Thank you. Kevin, what about your thoughts?
I would say that we took a different approach, and I talked about the private and public partnership, and public health was at the table for every meeting and every discussion. Collectively, we came together and developed a dashboard that was used for the city so that people could become informed. But when we started looking at what the resources would be needed just to manage the public health piece, those resources weren't there. And that's the point that was being made. It's just been underfunded. And so it was a moment where, once again, I want to go back to competition doesn't matter. I realize in the Deming, that's one of the strategy, but if you're responding to this kind of pandemic, it takes all of us within the city coming together. And I've got to thank University of Maryland. I've got to thank our Care First leaders. I got to thank our mayor, who came to the table and said, you're right, we've got to do this. And I've also got to thank the Secretary of Health and Human Services and our governor for allowing us to try a different model in this region that would bring us collectively together to respond to the public health crisis. Because we've used resources from both organizations, Maryland and Hopkins, to go out into our communities and do nursing home testing on all of our nursing home patients and providers. And so clearly, I think in the future, one of the questions we're going to have to ask ourselves is, because especially as we become more ambulatory in nature and not as hospital focused and more health equity focused, we're going to have to challenge ourselves about the governance structure. We're going to have to challenge ourselves about how we manage the structure of the organization. And we're going to have to manage ourselves around changing key processes that will support that transformation. And I believe that's our responsibility as senior leaders.
Thank you. And my very last question is, I always say that epidemics know no borders, obviously, and this is very evident with the COVID-19 pandemic. And I think I'm just curious in terms of your day-to-day work and the implications of supply chain and PPEs and the shortage of PPEs and all of a sudden the realization not only that infections are happening anywhere and everywhere, but also supply chains and people and movement and so on. I'm just curious as to how you felt and how your organization dealt with issues that were beyond the local. Maybe Craig, you want to start quickly?
Sure. I think that we, like many industries, have used the digital economy to have a supply chain that was just in time. And we've come to realize that with the unknown that COVID exposed, we need to have more redundancy in the system to be more self-reliant on the resources that are necessary to handle the unexpected. So we'll rethink the supply chain, both locally, but also we have to now have a partnership that extends so that when things break down, there is some redundancy in at least the healthcare supply chain. We can't have all of the gloves in the world being supplied from rubber in Malaysia. So when then that country closes its borders because of an epidemic, we can't supply healthcare throughout the rest of the world. And so we will have to really, and that will take not just national, but even international cooperation to understand that as we deal with a pandemic, which is by definition the world's health.
And maybe Mike, could you touch on maybe and maybe Kevin as well, another perspective on this is the importance of flow of information. I think for many clinicians here, we learned by connecting to people who had seen it before us, and the scientific community and the importance of the global connection. Maybe Kevin, you want to go next?
Yeah, the importance and value of the global connection for us is that not only did we develop and share our policies and procedures around COVID care because we collectively came together, and with Maryland, we said, we're going to put our experts at the table, and we're not going to have one academic medical center doing something different, because we'll spend every day trying to explain why Hopkins did something than the University of Maryland. So we started that as a framework. I would tell you, as we expanded that and really began to look at supply chain, I think my colleagues would tell you, there's a lot of people who will approach you that they have PPE to sell you, but I can tell you horror stories where I had semis sitting outside a factory in China and were promised masks. They sat there for 3 days, but they sold them to the highest bidder. So we've seen price gouging during this time because we have masks that we used to pay a little under $1 for, and now we're paying $4. So it's not just about the supply of supply chain, because we did very well in having enough PPE for our workforce across the health system during the first surge, and we have now stocked up to where we have enough supplies, PPE for a second surge. But it's a bigger issue. We hired up just a part of our workforce that their full-time job every day is they come to work and assure that the company that we're about to buy from is real. Because we found that many good people came forward wanting to help us and said, I've got this, this, and this, and they weren't coming from real companies. So it's more than just systematically approaching. You have to have checks and balances built into your supply chain in a time like this.
And Michael, last word.
Yeah, a couple of lessons from the experience recently is obviously we have a huge national issue that we have to deal with here, but I don't get in out of time to get into that here. But I think every organization, whether they're healthcare organizations or non-healthcare, have to build into their DNA a culture of preparedness. Bad things are going to happen. Bad things will happen again in the next 10 years. So I think every organization has got to sit back and say, okay, let's assume a bad thing is going to happen. What are the core ingredients and what are the core supplies that you may need and talent that you may need to deal with that kind of a crisis? That, I think, is one of the great lessons. Now, in our case, we developed our own GPO, group purchasing organization. We have our own supply chain infrastructure. We have our own distribution network. I have my own warehouses. I have supplies for months, not just for COVID, but for any issue that goes on in any of our hospitals. I have all of that built in. We built that in about 10, 12 years ago. We did it in other areas as well. But I think any leader in every organization should be looking out to the future and saying, bad things are going to happen. How do we get prepared? It's our obligation as leaders to do it. Nationally, we have to have the same thought process. How do we do domestic manufacturing of PPE? How do we get our stockpiles current and up to date? How do we expand it? We should be developing them domestically, because when you're fighting a virus, you're fighting a war. You have to have the munitions to be able to fight the war. You can't be dependent upon one or two of other countries to be able to supply you these unbelievably important things that you need. So I think organizations themselves, healthcare and non-healthcare, has to take on this as a leadership challenge. How do I get prepared for the inevitability of a future crisis? It's down the road. It's going to happen.
Thank you. Thank you very much. And I want to end with just one thought. And first, I want to thank you all. In one of our prominent medical journals, the England Journal of Medicine, had a remarkable editorial recently with the title of Dying in a Leadership Vacuum. I'm glad to say that we have fantastic leaders here amongst the three awardees of the Deming Cup, and we are all very fortunate to have you at the helm at these very, very important institutions in our country. So thank you very much and congratulations to all of you. I hand it back to Nelson. Thank you.